Emily Fenton and Mia Sorkin are both physician assistants. Emily is in the Department of Surgical Oncology, or the section of Surgical Oncology, and Mia Sorkin is in Gynecologic Oncology, and they're going to give a presentation together about the role of the physician assistant in cancer care. And I'll turn it over to them.
Great. Thank you, Dr. Golden, for inviting us to do this talk. Again, I'm Mia. I am working in gynecological oncology, which covers all reproductive cancers: vulvar, vaginal, cervical, uterine, ovarian, fallopian tube. And then this is Emily. I'll allow her to introduce herself again.
Hi there, good afternoon. So I'm Emily Fenton, and I work in a subset of surgical oncology as part of the Regional Therapies Program at the University of Chicago, where we specialize in managing patients with disease that's spread to the peritoneum or peritoneal surface. So we'll talk a lot about that today. We don't have any disclosures.
Okay, so here are our objectives for this discussion. Some of you may or may not have encountered physician assistants already in your career as healthcare professionals. So we'll start with some basic information about physician assistants, who we are, how we've trained, and where we work. Emily and I will each review two of the more common diseases that we diagnose and treat in our respective fields. And then we'll identify and describe the role of a physician assistant throughout the cancer care continuum. And then finally, with a broader lens, we'll discuss more specifically how physician assistants contribute to the healthcare system, and then as a part of our multidisciplinary teams. So I'm looking at you, everyone in the audience. You guys are the future of our healthcare field. So as healthcare providers, it's useful for you to know all members of your team. And Dr. Golden told me that you've been meeting some other allied health professionals throughout this seminar. So you will learn that PAs are invaluable resources, both for your learning and as your future practice as providers in your practice.
So we're going to start with something a little fun. I'm going to share my screen here, and we'll pull up a poll for you to take. It may not allow me if Mia is.
I can stop sharing.
For the questions. Okay. So let me see if I can pull this up. You know what might be easier, Mia, is why don't you just bring the questions up, and instead of polling,
Sure.
you can just discuss. So I'll stop.
The answers were there.
If they can do a kind of show of hands with the chat box or the
Yeah, that would be fine.
participants box.
My very graceful transition on Zoom. Here we go.
Okay, so we'll run through a few questions just to get a baseline understanding of where you are, what you understand about PAs. The first question, these are all just true-false questions. Physician assistants are able to conduct clinic visits with oncology patients independently of the supervising physician. Do you think that's true or false? If I can get a show of hands or chat response. Great, getting a lot of trues. Okay, we'll move on to the next question. Physician assistants can order and prescribe chemotherapy. True or false? Okay, we'll move on to the last question. Physician assistants can sign orders for hospice care. Great. Good job, everyone. We'll actually review the answers at the end, so we'll keep you in a little suspense there. We'll move forward with our presentation now.
Okay, what is a certified PA? So a physician assistant is a licensed and certified healthcare professional. We practice medicine, meaning we are capable of diagnosing, evaluating, counseling, and treating patients, including prescribing medications and therapies. And we work in partnerships with our physicians to bring a breadth of knowledge to our field. The term here that I want to emphasize is partnership. So physician assistants and nurse practitioners are considered advanced practice practitioners, and our physician extenders, meaning we work very much in collaboration with our physicians and alongside their practices. So I'd like to just take a brief moment to highlight the difference between a physician assistant and a nurse practitioner. So they're both APPs, or those advanced practice providers, or mid-level providers is another synonymous term you hear a lot. Physician assistants practice or learn under the medical model, which is very similar to what you as medical students are learning in general medicine. Nurse practitioners practice and learn under the nursing model, which means they do go on to specialize in a very specific field. Sometimes that's general medicine or pediatrics or women's health. Nurse practitioners can go on to practice individually in their own practices, whereas physician assistants practice under a supervising physician. And I put that in quotes because the term supervising physician has really evolved over the years. Initially meant that you had to have a supervising physician immediately with you in your clinic. And then over time, that's kind of evolved to mean that the supervising physician can be simply in the same workspace, they could be on the same campus, or they could even be just a phone call away. So actually what physician assistants do on a daily basis can be very individual to their practice, but legally we do need a supervising physician. Nurse practitioners are certified and practice under one specialty, whereas physician assistants like myself and Emily can choose to switch specialties throughout our career. And we can also practice across all 50 states. So training-wise, it's very similar. The topics that we cover in our training is very similar to the medical model. Our program is truncated to 24 to 36 months, so 2 or 3 academic years. It is composed of both didactic lectures and then also clinical rotations, over 200 hours in clinical rotations. And then at the end of our training, we achieve a master's degree and then go on to complete a national certifying exam, which is called the PANCE. Once we're board certified, we can practice in all 50 states and move pretty seamlessly between specialties. And then we do have to continue our medical education with about 100 hours every 2 years, and we do recertify every 10 years. So what you can see in this graphic on the right is while initially physician assistants were created as a role to fill gaps in general medicine and primary care, physician assistants now work across all specialties. So pretty much wherever physicians work, PAs work alongside to support them. And we also work in a variety of different settings, ranging from academic settings like University of Chicago to more rural settings or private practice. So PAs are definitely making themselves prevalent in our modern day healthcare system.
Thank you, Mia. So now that you sort of understand better the background and training of a physician assistant, Mia and I wanted to give you a peek into what we do in our current roles. So we're going to talk to you about a couple types of cancers that she and I both deal with quite frequently. So I'll talk to you about appendix cancer. We'll walk through the presentation, how you diagnose and treat it, and then give you the opportunity through a case study to sort of live in the day of a life of a PA and help us diagnose a patient with their cancer type. I do like to point out University of Chicago is a world leader in the management of appendix cancer in terms of the number of patients we see and operate on each year. It makes up about 30% of our cohort. I have a bunch of information here, but really the takeaway I want you to know is that appendix cancer is extremely rare. It makes up less than 1% of all cancers. Colon cancer is 100 times more common than appendix cancer is. We don't really understand the risk factors for appendix cancer, but I think it's an interesting area of research where we think it may be related to the gut microbiome and the appendix's role in harboring gut bacteria, and that may play into the pathogenesis of appendix cancer. The presentation of appendix cancer can often be appendicitis. Unfortunately, that appendicitis is often paired with peritoneal disease. Appendix cancer is classically very silent for a long time, and so it tends to present in advanced stages. So patients may also have nonspecific abdominal bloating, and that would be representative of peritoneal disease. Perhaps the peritoneum is irritated from that peritoneal disease and creates ascites or fluid in the abdomen. Not uncommonly, appendix cancer can also present with adnexal masses. So we can have an issue with a patient having an adnexal mass and that be misdiagnosed as ovarian cancer, but in fact is from a GI primary and from the appendix. In terms of diagnosis, I listed what a patient with a new diagnosis of appendix cancer would need in terms of full staging. They would need a CT, most commonly of the chest, abdomen, pelvis with contrast to look for metastatic sites of disease outside of the abdominal cavity. We need some sort of biopsy. Often these patients have had their appendix removed, and that's the way that we diagnose them. They need a colonoscopy. Tumor markers specific to appendix cancer, the CEA is what we often use in colon cancer that can also be elevated in appendix cancer. The CA-125, we also get in appendix cancer. This is commonly used for mesothelioma. It's commonly used in ovarian cancers, but it's also produced by the peritoneal lining. And so we do check that in appendix cancer to make sure that it's not elevated and can be indicative of peritoneal disease. CA-19-9 is another tumor marker that's more representative of hepatobiliary cancers like pancreatic or gastric cancers. It can be elevated in appendix cancer, though I don't see that commonly. It is part of a complete workup for appendix cancer. CRP is not a tumor marker, it's an inflammatory marker, but it can also be elevated in appendix cancer, and we use that as a predictive marker. When elevated, it's a negative predictive marker for our ability to resect peritoneal disease. We think that that means the disease is more inflammatory and could be more stuck on in the abdomen. Because CTs and MRIs are classically poor at identifying peritoneal disease, the peritoneum is a very thin layer of tissue coating the abdomen. We often include a diagnostic laparoscopy to stage our patients to look for peritoneal disease. Histology is the #1 most important thing to know when you're dealing with appendix cancer. Appendix cancer is not just one diagnosis. There are many different types of appendix cancer. There are different ways to classify this. One is mucinous versus non-mucinous. Most appendix cancers arise from glandular tissue that makes mucin, so we see that most appendix cancers are mucinous types. We can also think about appendix cancer in terms of its grade. Grade has to do with what the cells look like under the microscope. There are many different types of ways this can look, but I'm breaking this down into low grade and high grade for you. On the left, you can see some examples of low grade Lamb-Hammond neuroendocrine tumors. Low grade adenocarcinomas on the right-hand side are more high grade types of histologies. And that really guides the treatment for appendix cancer. What also guides the treatment of appendix cancer is the stage. So where is the cancer located? I won't go through this in great detail, but I'm sure you're familiar with the TNM staging that we use for many cancer types relating to how invasive the tumor is. That's the T stage. N represents nodal status. Has the cancer from a particular organ metastasized to lymph nodes surrounding that organ, or has it gone into other organs and metastasized, that being the M. The peritoneum is one of those sites that we consider an organ that it can metastasize, so that would be an M stage. Treatment, I'll kind of focus on stage 4 disease, would include often chemotherapy, followed by surgery, followed by chemotherapy again. And we call this the chemo sandwich for stage 4 disease, where the patient does chemotherapy initially to try to control their cancer and perhaps shrink it and make surgery easier, followed by additional chemotherapy to address any microscopic remaining disease. The type of surgery that we use in stage 4 disease, when limited to the peritoneum only, when it's metastatic to the peritoneum, we would call that cytoreductive surgery in HIPEC, and we'll talk more about that later. And the chemotherapies that we use systemically, first line in the US is FOLFOX, second line would be FOLFIRI, and I won't talk too much in detail about those either. This is just a photo of the T stage in appendix cancer. So this is a cross section of the appendix, and you can see in the upper left, the green blob is a T1, and as the tumor invades through the mucosal, muscular, and serosal layers of the appendix, the T stage increases. So that's represented here.
Okay, let's talk briefly about ovarian cancer. Ovarian cancer comprises 22% of all gynecologic cancers. It also comprises 47% of all gynecologic cancer deaths. It is about the 7th or 8th, depending on your source, leading cause of all cancer-related deaths, so it carries a pretty high mortality. 14 in 1,000 women are afflicted by this disease in the age over 40. So it does disproportionately affect older women. However, the type of ovarian cancer kind of depends on the histological type, and it does affect women across all age groups, which does depend on the histological type. So with germ cell tumors, for example, we see that mostly in younger women, younger than 20, whereas epithelial cancers, which I'll point out on the next slide, is the more common type of ovarian cancer, and we predominantly see that in women older than 50. Some risk factors include unopposed estrogen and endometriosis, but there are genetic risk factors that you probably have heard of, like BRCA1 and 2 mutations carry about a 20 to 40% lifetime risk of ovarian cancer and 10 to 20% lifetime risk, respectively. And also hereditary non-polyposis colorectal cancer is associated with this disease as well. So presentation and workup, you're going to hear some familiar terms from Emily's previous slide. So common presenting symptoms would be bloating, abdominal pain, very nondescript symptoms. Sometimes the woman might experience urinary frequency from pelvic pressure or changes in her bowel function, like constipation. You could have weight gain or weight loss. Weight changes kind of depends on if you have the presence of ascites, but sometimes decreased appetite would cause a patient to lose weight. Diagnostic testing is a combination of both imaging and blood work. So blood work would be, as Emily pointed out, there are some serum tumor markers that we can help differentiate between what's higher on our differential for a malignancy, CA-125 being more specific for gynecologic malignancies. Often when diagnosing or working towards a diagnosis for a pelvic mass, we would get all 3 of these tumor markers. CEA can also be elevated with ovarian malignancies as well. CA19 usually within normal limits. As far as imaging, if a patient's coming through the ED, sometimes they'll just pan scan that woman and she'll have a CT already, but it's important also to get a transvaginal ultrasound to better visualize the adnexal structures. A cyst or a mass in the pelvis that might be concerning for ovarian malignancy would be maybe more solid in appearance, have multiple septations on the ovary, have increased Doppler flow, what could be characteristics that would be concerning for malignancy. But in order to diagnose an ovarian cancer, we need tissue. And tissue can come in many forms. It can be ascites or pleural effusions that are malignant in nature. We can drain these fluids and test them for their cytology to get about a diagnosis. But oftentimes we want tissue diagnosis. So if the disease has metastasized to other sites like the omentum, which is a fatty curtain over the abdominal and pelvic organs, we can obtain a percutaneous biopsy of that tissue for diagnosis. Sometimes lymph nodes will look enlarged and we can biopsy that. But the ovary itself, we never want to biopsy directly, as breaking the capsule can actually cause seeding of malignant cells into the abdomen. So if we do obtain a biopsy by the ovary, it would be removing it in its entirety. So BSO is a bilateral Salping oophorectomy. I briefly touched on histology. So 95% of these ovarian cancers are arising from the epithelium, 5% from other types of cells like germ cells or sex cord stromal tumors. Staging I won't go too much into because I really want to get to the bulk of our presentation about our roles in cancer care, but staging uses the TNM system. As you go up in staging, the cancer moves from the ovaries and pelvis up into other abdominal structures. Treatment, like Emily was describing with appendiceal cancer, is dependent on what staging we are able to elucidate from imaging or from surgery. It's a combination of both chemotherapy and surgery. And depending on what stage we think that the patient is up front, we might recommend surgery first if we're able to get all the disease out. Or sometimes we'll do neoadjuvant chemotherapy, which is chemotherapy first to stabilize or shrink down the size of the tumors, and then approach surgery later when it has a higher chance of removing all visual tumors. The 2 chemotherapy agents that are most commonly used in gynecologic malignancies that I'll briefly touch on later is carboplatin and paclitaxel. Here are some nice pictures of, on a cellular level, what ovarian cancer can look like. We have here on the left side what the epithelial cancers look like under the microscope. And then, as both Emily and I mentioned, these tumors, both appendiceal cancer and ovarian cancer, can metastasize to the omentum and form this large plaque or cake on the omental tissue, which sometimes we can see on imaging, but you could see pretty profoundly in this gross image on the right.
Okay, so we'll talk a little bit more about cytoreductive surgery. So this is really for patients that have disease that's metastasized to the peritoneal surfaces. And this is a method of tumor debulking by stripping away the peritoneum along with the peritoneal tumor that's coating it away from the intra-abdominal surfaces. And this is a very advanced surgical technique, and it's not been around that long. So up until maybe 30 or 40 years ago, if we had a patient with disease that had metastasized to the peritoneum, they would have been considered inoperable, and we wouldn't have offered them a surgery to try to fix that. And so that would be a terminal event for them. But then it wasn't until Dr. Paul Sugarbaker from Washington Cancer Institute pioneered some of these surgical methods with the peritoneal stripping that we were able to offer this to our patients that have disease that's metastasized there. So it's really revolutionized our management of patients with stage 4 cancers. Yeah, and then when we're talking about the cytoreduction in HIPEC, we are really talking about how do we confer a survival benefit to our patients. And the way that we do that is by completely removing the tumor in the abdomen. So if we can't completely remove the tumor, that does have a negative impact on their survival. And so when we communicate this to our oncologic colleagues, as far as the completeness of our ability to remove tumor, we use the CC score, this completeness of cytoreduction score, with a CC 0 being our ideal optimal outcome where we leave no visible tumor remaining, but we can also categorize if there is residual tumor in this way using CC 1 through 3 to indicate that. HIPEC is heated intraperitoneal chemotherapy. And the reason why we heat chemotherapy and then place it in the abdomen is that we think the heat improves penetration of the chemo, and then we think that the direct contact on top of cancer cells will kill them. And so again, if we can remove all visible tumor, then our goal with the HIPEC is to treat any microscopic residual disease that's remaining in the abdomen at the completion of surgery. We're going to show you a quick video on what a peritonectomy looks like. I wanted for reference to show you a very healthy diaphragm. This is the left diaphragm. You can see the healthy pink muscle with that kind of whitish sheen overlying it. That is the peritoneum, very, very thin tissue. On the next picture,
There you go, super, sorry.
That's okay. Thanks, Mia.
Mm-hmm.
So you can see there's really a remarkable difference here. This is a patient with an inoperable appendix cancer, and you can see their carcinomatosis is very thick. The peritoneum looks very thick. All of that whitish deposit is cancer, and it's very sticky. You can actually see in the upper right corner, the spleen has been plastered to the diaphragm. So you can see that this could be very difficult to remove, and that you would need some surgical expertise to do this peritonectomy. In this video, before you start it, Mia, I'll just kind of say what you can see here, that sort of thin tissue hanging off the liver, which is what the surgeon is holding on to. That's the peritoneum, and you can see some whitish deposits on that. That's disease on the peritoneum. This was a fantastic case done about a year and a half ago for one of our patients, and we'll play it from here and show you the rest of the peritonectomy.
It is important to note that the peritoneal sac is maintained as one specimen.
So they use this electrocautery to very carefully peel back
To dissect the peritoneum off the liver, exposing the bare area. Any disease encountered in Gleason's capsule is resected with the specimen at this time, taking care not to injure the underlying liver parenchyma.
They show some really nice anatomy at the end of this, so I think it's worth it to look at this.
As we continue to work around the liver, the dissection planes approach the IVC and the right hepatic vein. Once this vein is reached, the dissection is complete and the specimen is removed en bloc from the final attachments. Once the specimen has been removed, the right kidney, right adrenal gland, inferior vena cava, muscle fibers, as well as the central tendon of the diaphragm should all be fully exposed, with no evidence of remaining peritoneum.
Have we convinced some of you to be surgical oncologists now?
So I think while Mia pulls this up, the next thing we'll do is move into a case study. Again, this is sort of your opportunity to participate, so feel free to answer on the chat.
Can everyone see the PowerPoint again?
Yes.
Okay, great. So as a part of our work, Emily and I both work on the outpatient and inpatient side. And on the inpatient side, we do see consults. So this is an example of a patient that might be consulted to us by our ED or hospital medicine colleagues. We got a 52-year-old. She's in the ED. She's had 3 months of abdominal fullness, this bloating sensation. She hasn't been very hungry. She's not nauseous. She's not throwing up, but she's had worsening constipation. She's tried everything at her CVS and nothing is relieving her symptoms. She notes that she's a little bit more frequent in her urination. She's got this vague abdominal pelvic pressure and pain. Her gynecologic history is listed there. She's been pregnant twice, has 1 living child. She's never used contraceptives, oral contraceptives therapy before. She has no history of endometriosis. She never had any surgeries. Of note, her maternal aunt had breast cancer. She is a smoker and sometimes she likes to drink with her girlfriends on the weekend. What do you have kind of on your mind as far as the big, bad, and scary that could be plaguing this patient, or some more common things that she might be facing that brought her to the ED? And you can write in the chat or speak out. I'm just going to give a couple seconds in the face of time to move on from this. Any thoughts? All right, you will after this. Okay, so you do a physical exam. Her heart and lung sounds great. On her abdominal exam, you notice some ascites, which a fluid wave is a way that you can detect that on physical exam, and it is present. She's distended for her body habitus. You listen to her bowels. It sounds like she's got some things moving in there. She has no surgical scars. Because she's a lady and she's having some pelvic pain, you astutely decide to do a pelvic exam. Her external genitalia looks normal. You do a speculum exam. Everything looks okay, no bleeding. On bimanual exam, which is when you insert 2 fingers into the vagina and feel the pelvic organs, you notice that there is some fullness on the left side, but nothing discrete that you could feel. But you notice that everything's kind of limited because she's got all this fluid in her belly. Now, hint, hint, wink, wink, what is on your differential diagnosis for this patient? Any thoughts in the chat? Sure, appendiceal cancer. A win for Emily on that one.
Yeah, thank you.
Anything else? She only has an appendix?
Any
I would say ovarian cancer,
Oh.
certainly on the differential diagnosis. Uterine cancer, cirrhosis leading to ascites, great. These are wonderful thoughts. So again, on your differential, you want something that could be benign. So you could definitely have benign ovarian findings like cysts or non-neoplastic tumors on the ovary. The uterus can have fibroids that get kind of pedunculated and hang off that could present as an adnexal mass, but also given the proximity of all the adnexal organs, like the appendix, like you said, you could have abnormalities there, or other GI malignancies from the cecum, the sigmoid, even the small bowel. So great. Ectopic pregnancy for sure. Okay, so you get an ultrasound because she's a lady and she's having pelvic pain, and it reveals this complex looking 11 centimeter left ovarian mass and the ascites that you felt on your exam. Her uterus and her ovaries look normal. The CT scan, because she came through the ED and they scan everyone, so she did get a CT scan, and this is what it looks like. And this looks pretty funky. Our radiologist very helpfully pointed out this 11 centimeter mass. But also this gray stuff is not normal, should not be there. And so what we're seeing there is the extra fluid that we felt on exam. The peritoneum, which is kind of this enigma that Emily described that lines the abdominal and pelvic lining of the cavity here, is supposed to be a very thin, smooth line, but here we see there's kind of roughness to it. It looks like nodular, it looks thickened, so that could be indicative of disease that's spread to that lining.
We also, because we see this big mass, we're concerned about a malignancy, so we went ahead and ordered some tumor markers to see if that can give us a little bit more answer. The CEA is a little bit elevated at 5, but she's a smoker. It can be elevated in that. It can be elevated for GI cancers, so that's on the differential, as well as ovarian cancers. The CA 125 is markedly elevated. It's 1526. We're concerned about that. That stands out. The CA 99 is normal. So now we're a little bit more suspicious. The next thing that we need to do is get a diagnosis. We need to understand, what is this disease? So how could we do that? What are some tests that we might run? Feel free to answer. Good. I'm getting aspirate ascites, sampled ascites. Exactly. So in this patient, we got some ascites. We performed a paracentesis. The results came back as adenocarcinoma. So we are dealing with a cancer, but do we know where the cancer is coming from that? We don't. So how might we get some tissue hints or move forward with getting a diagnosis? Little hesitation on this one. So in this patient, we decided to go for a omental biopsy. We have that omental nodularity. It seems safe to biopsy that. So we're going to move forward with that as the least invasive way to obtain a diagnosis. So we performed that for the patient, and the biopsy results returned as high-grade serous carcinoma. So now we know this patient has an ovarian cancer.
Okay, so now you know what Emily and I see kind of on our day-to-day. So let's go into the PA scope of practice in oncology care. So this table here, you may have seen in the articles that were sent prior to our presentation. It basically outlines some specific day-to-day tasks on the outpatient side and inpatient side that someone, a physician assistant or an APP in gynecologic oncology might perform. While this is specific to gyn-onc, they actually can be extrapolated to most oncologic fields, including what Emily does in surgical oncology. So as I mentioned before, Emily and I both work on an inpatient and outpatient setting. As a gyn-onc PA, some special skills that are specific to my practice include in-clinic procedures, speculum exams, endometrial biopsies, cervical biopsies, colposcopies, paracentesis, thoracentesis. I'm credentialed to do these things. Emily does have some time in the OR, so she acts as a first assist. She has probably exceptional beyond mind suturing skills, helps open and close with her surgeons, and manages some pre-op and post-operative care for her patients. So in the upcoming slides, we're going to highlight our role as PAs in both pre- and post-operative care, management of labs and chemotherapy, and then surveillance and survivorship care.
Yeah, so I often see my patients in cohorts with my physician, with my surgeon, or with the gynecologic oncology team if I have a patient that I'm suspicious that they have some gynecologic issue as well as advanced stage disease. So those are the types of patients I'm seeing in clinic. And when we're talking to them about doing surgery, doing a cytoreduction and HIPEC for them, what I'm really doing when I see that patient before surgery is identifying ways that I can optimize their outcomes from surgery. So I look for ways that I can intervene early to do so. And so some things that I'm looking at that are very common for our patients, oftentimes they come to me after doing some chemotherapy, they're deconditioned, they're weak, they need to be sort of urged in the direction of doing exercises, perhaps doing an incentive spirometer to strengthen their pulmonary status. I may refer a patient to physical therapy for strengthening if I feel that they have some weaknesses. Certainly these patients come back after having a few operations and may need another operation. They may have weaknesses from their prior operations that I need to address and make sure that we rehabilitate to the best of our ability before their next surgery. Another very common thing that needs often needs optimization prior to surgery is nutrition. These patients, again, with chemotherapy have a number of GI side effects that we need to work hard to make sure that their nutrition is optimized before they have surgery to reduce their complications. So I have our nutritionist in a clinic that I may refer the patient to. Sometimes we need to be as aggressive as admitting the patient for tube feeds or for IV nutrition, TPN, so that they're ready for surgery. Patient education is certainly a huge part of my position. In the setting of preoperative care, I'm talking to them about their surgical risks and talking about the benefits and alternatives to surgery. I talk to them about surgical expectations, not only in terms of hospital length of stay, but also in terms of their prognosis. Why are we offering them this surgery? What do we think that that's going to benefit them? If they're interested in talking about prognosis, that's something that I feel comfortable talking with my patients about and talking them through. Our patients often come to us with additional needs that require my kind of identifying those things. So a young female patient who may need to have her ovaries removed may need to be referred for fertility preservation discussions. Patients that are having difficulty coping with their diagnosis may need to be referred to psycho-oncology. So these are some of the things. Social work, some of our patients also need some interventions that our social workers are best at managing. So it's part of my position to identify those things that patients may need and refer them to the appropriate specialists. Postoperatively, we also use aggressive interventions to make sure that our patients' outcomes from surgery are as optimal as possible. We use something called an enhanced recovery after surgery or ERAS pathway. And this is really immediately after surgery in the hospital stay, using a collection of evidence-based interventions, which we believe will reduce their risk for postoperative complications, speed their recovery, reduce their hospital length of stay. So things like multimodal pain control, ambulating our patients early, right after surgery, the day after surgery, initiating bowel regimens to avoid ileus, postoperative ileus. And so part of my position is ensuring our patients are on that pathway, make sure I teach the residents that come onto my service about the pathway and about the particular complications that these patients can have from their cytoreductions and HIPEC. And I do think this makes a big difference. The national hospital length of stay is 10 to 14 days. For cytoreduction and HIPEC at University of Chicago, our average hospital length of stay is 6 days. So I think it makes a huge, huge difference for our patients. Another part of my position is I run a postoperative clinic. So I am responsible for independently seeing patients after surgery, after they've been discharged from the hospital, to assess them for immediate postoperative complications. HIPEC certainly has its own unique set of complications. Just like systemic chemotherapy, the HIPEC can cause the white blood cell counts to go down, the platelets to go down. It's filtered through the kidneys, which can take a hit and be injured, and so we assess that. HIPEC also increases the risk for wound issues and infection like intra-abdominal abscesses. So these are all things that I might look for in a patient that's coming to my clinic.
Emily, there's a question from Alec. What are the consequences of living without a peritoneum?
That's a great question. So in the diaphragm, when we remove the diaphragm peritoneum, we may have patients that get pleural effusions, especially immediately postoperatively. So they may have respiratory complications from that. Typically, they're not long lasting as the body forms scar tissue. So in fact, we don't really see a lot of sequelae long-term from removing the peritoneum in the diaphragm even, or lower down or at the rest of the abdomen.
Okay, moving forward. Gynecologic oncology is a unique field because not only do our oncologists specialize in complex abdominal pelvic surgery, but we also can administer our own chemotherapy regimens. So as a part of a service and a team that does both surgery and chemotherapy, as a physician assistant, I also help manage patients' chemotherapies. As I mentioned earlier, the two most common the standard of care chemotherapy regimen for our more common ovarian cancers would be carboplatin and paclitaxel. Now, maybe for most of our audience, your basic science is a little bit more recent than mine was, but carboplatin helps bind to the DNA and interferes by producing these interstrand DNA crosslinks, whereas paclitaxel is an antimicrotubule agent that acts on tubulin dimers to help stabilize the existing microtubules in the G2 mitotic phase. Carboplatin both medications are administered through IV, and the biggest side effects for carboplatin is myelosuppression, meaning it hits the bone marrow and causes kind of it to be stunned and can't produce the fighter cells. It also causes nausea and vomiting for patients. Platinums are known for the GI side effects of constipation and fatigue. Paclitaxel, on the other hand, causes alopecia, meaning women will lose their hair, which can be kind of the most traumatizing side effect for a lot of my patients. Also cause peripheral neuropathy, so numbness, tingling in your hands and fingers and toes. It could be burning, numbness, tingling. It also causes a degree of myelosuppression as well. So as a physician assistant, I see our chemotherapy patients on the week of or week before their scheduled chemotherapy. A typical regimen administers chemotherapy every 21 days. So I'd see them right before they're due for their IV chemotherapy. I provide chemotherapy education as well as can consent them for chemotherapy. During these visits, we do typical normal visit things like a physical exam, but also review labs will be important. As I said, both carboplatin and paclitaxel can cause myelosuppression, so it's important to look at their absolute neutrophil count to see if it's appropriate to administer further chemotherapy on schedule. With some of the novel immunotherapies that some of our recurrent population might be on, we have to look at hormones like thyroid hormone, urine protein, just to name a few. And then during these visits, I really review with them how the chemotherapy is being tolerated, and based on their responses and functional status, make some decisions as to whether or not they can move forward with chemotherapy, or if the dosage of the chemotherapy needs to be adjusted to reflect the grade of the toxicities the patient is experiencing. So physician assistant, depending on the institution, can order chemotherapy and manage chemotherapy. At University of Chicago, in our practice, I can do treatment modifications, but the initial treatment orders are placed by our physician. It's a little bit institution dependent in that way.
So after a patient has gone through their surgery, they've had chemotherapy, they really enter the next phase of care, which is called surveillance, where we continue to monitor them and make sure that their cancer doesn't come back or address it if it does. And this typically lasts 10 years or so, though this can be a little variable. And initially, they're coming every 3 months. So a patient's coming every 3 months to your clinic for history and physical. They're getting imaging done, usually a CT chest, abdomen, pelvis. They're having their blood work drawn, including those tumor markers, and we're kind of continuing the journey with them. Initially, surveillance visits are staffed jointly at our institution with myself and our attending physician, and then that transitions oftentimes to alternating visits, and eventually I may completely take over the surveillance of a patient.
Survivorship care or survivorship program is just a formalized way of saying exactly what Emily was explaining. Performing surveillance visits with kind of a more broad lens to really capture the patient as a whole and what their needs are across the cancer continuum. So survivorship actually starts at the patient's initial diagnosis and goes across their entire lifespan. So PAs are really uniquely positioned to perform needs assessments for patients after they've completed treatment. And really their focus becomes less on the symptoms that were plaguing them during treatment and more so to the sequelae of being a cancer survivor and maybe some more broader needs that they might have. So with better treatment options, patients are surviving longer, which means some of the issues that cancer patients might have after their treatment are very similar to that of the general population, but also some of them might be cancer specific to their treatment sequelae. So during a survivorship care visit, we would do a needs assessment, which is a quick survey to kind of get a baseline assessment of what the patient's predominant issues are, whether they be physical, social, emotional, perform a physical exam, do some follow-up tests. So for ovarian cancer, typically we have them get a CA-125 to continue monitoring their disease, which is that blood test. Sometimes we'll review imaging if they have a surveillance imaging due at that visit. But a lot of the care in survivorship or surveillance might be referrals to specialists, which could be in the form of emotional support through our psycho-oncology program, nutritional support with a skilled nutritionist that deals with specifically oncology patients. In ovarian cancer and gynecologic cancers, we do address their sexual function. So at University of Chicago, we have a PRISM clinic that addresses specifically sexual function in these patients. And then some of it might be even financial support, like chemotherapy is not cheap, and sometimes insurances can't cover expensive therapies. So hooking these patients up with financial support through a social worker or what have you is kind of part of our care to connect them with resources. So here's a schematic that basically outlines very similarly what Emily and I just explained, which I'll gloss over. So finally, physician assistants, when it comes to the cancer continuum, do manage end-of-life care. And this involves initiating some difficult conversations with patients that we've developed relationships with over the course of their treatment. It is a holistic approach that does address the patient as well as their family members. And physician assistants play a pretty direct role in symptom management, so understanding their pain or their nausea and prescribing appropriate therapies based on that, doing therapeutic procedures, or really engaging other consults like palliative care. You might have had a talk about already as a part of this seminar, deals with more symptom management in this setting. Social worker can be helpful for hospice referrals to different agencies. Physician assistants cannot specifically order hospice orders, but we can initiate these conversations and have them referred to different agencies that can manage that. Physicians have to sign the orders specifically. Similarly, we can't sign DNR/DNI paperwork, which is addressing the idea of code status, like do not resuscitate, do not intubate. But we do lead these conversations with patients and their families and explain to them the implications and the meaning of these procedures in end-of-life care. So I would say personally, some of the deepest relationships that I've had with patients and their families have been in this phase or stage, which can be very difficult. But in the end, families, even after patients pass, are appreciative or come back to me and still keep in touch about, you know, how grateful they were that we were part of this process. So I think after going through the whole cancer continuum, you can see that there is great value in having PAs in our practice. And certainly that translates to patient outcomes. So physician assistants spend over 80% of our time in direct patient care. And Emily and I serve as kind of a stabilizing force as patients come in and out of outpatient and inpatient care. We're kind of that phase that crosses both and able to relay a patient's history to the resident team, kind of fill the physicians in the gaps about their social needs, things like that. In a survey of in 2014 of over, I believe, like 1,500 patients that have had interactions with physician assistants, over 90% of them expressed that physician assistants were qualified members and trustworthy providers in their care. And also, I would make note, physician assistants do make it easier for patients to get medical appointments. So our physicians spend half their time in the OR. So it's nice that physicians or our patients can also see PAs in clinic to get care in a shorter interval of time.
And certainly a huge part of our job is education. Really, every time that I meet with my patient, be it in the hospital setting or in the clinic setting, I'm educating them, I'm talking with them and talking through their diagnosis and answering their questions and facilitating their care. I think more relevant to you, really it's important to recognize that PAs over time, we develop experience and clinical expertise. And so we are a huge advocate and supporter of our residents that come on our services, and we're here for you to help you learn what we know. And so don't forget about your PAs when you are rotating through, that we are there for you and we are happy to share our knowledge and expertise with you. I think another really cool way that PAs can be involved in education is one I'll sort of highlight with our malignant bowel obstruction pathway. And malignant bowel obstruction is when cancer obstructs the intestines, and this can be a terminal event for our cancer patients when this happens. And it takes a lot of expertise across multiple disciplines to understand how to manage these patients well. And what we found in the past is that these patients end up sitting in the hospital for weeks as we try to coordinate the care for these patients and understand what the best thing to do for them is. And so at our institution here at University of Chicago, we gathered a team, including myself and other PAs, NPs, and many experienced and expert physicians and people from all specialties and disciplines came together. We created essentially another ERAS pathway, an enhanced pathway to help manage patients that have this problem. And so we've really seen that the hospital length of stay has come down with this, and this has really highlighted, I think, the role of the PA, not only in helping implement this pathway, but it's really been an opportunity for me to be able to educate across subspecialties in our institution, and continuing to ensure it being implemented as another form of education as well.
So as part of my role in the inpatient setting, I also serve as a liaison with our case manager and social worker to make sure that our patients are having safe discharges that support them at home or in whatever setting they need with the care that will lead to the most optimal outcome from them. So, for example, doing a needs assessment to see if the patient needs physical therapy or any skilled nursing needs at home, medical supplies, or if the patient has a poor functional status, helping transition them to subacute rehab or even hospice if that's the point of care that they're at. So a physician assistant, just to emphasize Emily's point, does function across all specialties and provides an ancillary providers to provide the best care for our patients. I'll highlight tumor board, which is a big part of what Emily and I both do. Gynecologic oncology has a tumor board every week where we meet with different professionals that help contribute to our patients' care to discuss challenging cases. So this meeting that occurs weekly will include our gynecologic oncologists, medical oncologists, radiation oncologists, chemo nurses, pathologists, radiologists, all to discuss the most challenging cases in our practice. So, oops, I don't know why that's, sorry about that. Okay, so as a physician assistant, what I do at these tumor board meetings is present a very succinct protocol that details the patient's history, and we'll also go through their workup thus far so we can discuss treatment options. And it also educates me as a physician assistant to be part of these discussions so that I can understand the patient's disease process and educate them about their treatment options in the clinic setting.
Physician assistants are also certainly involved in research and can be involved on many fronts of research. I primarily am involved on a more clinical level where I identify patients that are eligible for these studies. We have a couple cool ones going on right now. I think in the interest of time, I'll gloss over these quickly. The cell-free DNA study we have, we're trying to develop a new tumor marker like a CEA that works even better than the ones we have. We're very excited about where that's looking right now. We also have an MRI study where we are trying to look at contrast timing protocols and imaging techniques to better evaluate the peritoneum, which, if you remember, I said that's really hard for us to see on traditional modalities. So we're excited about that study as well, that we can evaluate peritoneal disease and identify it sooner.
Again, in the interest of time, I'll just gloss over. The ovarian cancer tissue study is a part of Dr. Lengel's lab at University of Chicago, which is aimed at helping to basically genome the entire female reproductive system in the interest of learning more about ovarian cancer and how to find new novel targeted treatments. So I'm a part of the recruitment and data collection process for that. And then as a part of an academic institution, we are a part of clinical trials that offer other treatment options to our patients that have progressed through other lines of therapy. So identifying eligible patients for novel clinical trials, phase 1 trials, is part of my role as well.
We'll just quickly revisit these questions that we started with at the beginning of the presentation. I think it takes a second for these to load.
There we go.
The first question, certainly physicians are able to conduct visits independently of the supervising physician. I think you all got that right. We can order and prescribe chemotherapy, though there can be some institutional or physician preference limitations to that. I think you guys all got that right. And then hopefully you heard through the presentation that though we can certainly refer patients to hospice care, it is a physician that has to sign those orders.
So now we'll take your questions. If you want to learn more about physician assistants or be an advocate for our profession, AAPA is .org is a nice reference, and also the nccpa.net is another reference point where you can be plugged into what we do and help grow our career. Thank you.
Thank you.
Great. Thank you so much. That was awesome. It's 4 o'clock, but we could take a couple minutes to take questions maybe while folks, if you need to take a break. Dr. Sutter joined us, but we'll maybe plan to start again at 4:05. But are there any questions for Emily or Mia? Silence. I guess maybe we were talking about it right before, but if you maybe want to kind of revisit what I asked you. I thought it was interesting what you said about kind of the title of physician assistant and what in your profession had actually voted or on a survey suggested changing it. But it hasn't happened, obviously, but I thought that would be interesting to maybe discuss briefly.
Yeah, so I think there's been some question over the years of whether physician assistant is the right title for us, and if that really encapsulates what we are capable of doing in our role. And so there has been some discussion of whether we need to rebrand ourselves or not. So that was brought up through a survey to the PA community by the AAPA, I think about a year or two ago. And there was consensus through the community that perhaps physician assistant denotes some things that maybe does not fully reflect what we're able to do. But I think after some long discussion, things have remained the same. We are still considered physician assistants. Some alternatives, I think, were physician associates, but that didn't pass through a higher up vote through APA. So, but it is certainly something that's interesting, and I think that PAs think about a lot and have some differing opinions on, because we do want to make sure that we're advocating for ourselves and that the rest of the medical community sort of understands what our role is capable of.
Yeah. All right. Well, that was a great talk. I learned about what physician assistants can do and can't do. So thank you very much. Let's see. I will, or if you don't mind unsharing your screen, and we'll get. Oh, there is another question. But if maybe I can also get Dr. Sutter set up. Curious, what do you feel is the biggest differentiating factor between you and a physician? From Maniza.
I can give, I don't know, Mia, why don't you go first since I answered the last one?
Well, I would say in my day-to-day practice, besides the fact that as a gynecologic oncology PA, I don't go to the OR, but I think the physician is still is considered the expert in the field and kind of makes the big picture decisions for our patients and their treatment course. And then as a PA, I am more hands-on with the day-to-day ins and outs of the patient's treatment and kind of beyond, like knowing what's going on in their lives, how's that impacting their care, which as you know, anyone's social situation or other healthcare conditions can impact the way that we treat them in one siloed area. So, I think that the physicians are a bit more big picture in my specialty, and then I pretty much function in the same role almost as a physician on the day-to-day basis in a lot of ways.
Yeah, and I think that's really because of the training differences. So a physician has, 10 to 15 years of training as a medical professional before they're handed that responsibility to be a physician, an attending physician. And so a physician assistant, our strength and sometimes our weakness is that our experience is bought over time, but it's in the clinical field. And so there's just a little bit of difference there where you may see an earlier PA may not have the same responsibility set as a more experienced PA would have.